Moving on to the determinants of the central venous pressure. We want to know what determines the pressure of a distensible object, and that's really defined by its volume and compliance. And this is something that you must know really before stepping foot into intensive care unit. The compliance equation. We're almost always measuring pressures within an organic distensible object, like the right atrium or like the lungs. The cranium is not so distensible, but this is defined. The pressure is defined by this equation. This is a rearrangement of the compliance equation. So some of you who are very keen on physiology and physics will say, what's Kenny talking about here? He doesn't know anything. Compliance is really the change in volume over the change in pressure, and that's true. And that a total pressure for a total volume is actually the capacitance and not compliance. But just for internal consistency, let's humor me and call this compliance. So at physiological volumes, the right atrial pressure or central venous pressure and right atrial pressure I'm going to use interchangeably throughout this lecture, and barring any central caval obstruction or anatomical anomaly, I should say, they are interchangeable. And normally the compliance is fairly high, so change in volume causes a relatively small change in pressure. But I think, as I talked a little bit about in the previous section, that at very high volumes the compliance of the cardiac chambers actually changes, because the pressure-volume relationship of the atria and the ventricles is curvilinear. And this is true for much of the body, where you can usually fill something to a certain volume, and then when you hit a critical volume, then the pressure just shoots up exponentially. And the same is true of the right atrium. But for this discussion, we'll say that the pressure is directly proportional to the volume. That is, as volume goes up, pressure will go up, and inversely proportional to the compliance. And the compliance, as I said, can clinically affect the atrial pressure, and this is usually at very high volumes, and typically more so in the left atrium, because the cava, the superior and inferior cava, actually kind of act as compliance buffer zones for the right atrium. So high volumes in the right atrium can some of the pressure can be swallowed by the inferior and superior vena cava, and that's much less true in the left atrium. The pulmonary veins don't provide the same kind of reserve that the cava do. So this compliance change is more of a problem in the left atrium. So the question is, we want to know what determines central venous pressure, so then what determines central venous volume? So if you imagine this is the right atrium here, and we're going to pretend this is like a stream going in this direction. So if this were like a stream with fluid coming in and fluid going out, then the volume of the right atrium would really be determined by relative inflow versus relative outflow. I think that's pretty self-explanatory. So then the question is, what determines inflow into the right atrium? Well, go back to chapter 2, or really chapter 3 and 4. This is discussed very heavily in my talks, and this is the Guyton venous return curve. And this is it's beyond imperative that you understand this curve to practice intensive care medicine, I believe, and you have to understand this to understand the CVP. This inflow volume, that's blood flow on the y-axis here, and right atrial pressure on the x-axis. The pressure head here, we've already talked about. This is your mean systemic pressure. That's the pressure pushing flow into the right atrium. And that is this point here. That is, if I were to arrest the circulation, make the y-axis 0, zero blood flow, and measure the pressure in the right atrium after everything's equilibrated, this will roughly equal your pressure head, your mean systemic pressure. And again, this is also a recapitulation of the compliance equation. Your mean systemic pressure is equal to volume over compliance. And in this situation, it's the stressed volume. This is your the stressed vascular volume. And the difference between stressed and unstressed volume in the venous capacitance beds, you can think of it as like a balloon. If you've ever blown up a big balloon or a beach ball, you have to add a certain amount of volume before the walls of the balloon or the ball start to tense. And so the volume that's added before any tensing of the walls, that's your unstressed volume. And then the volume above and beyond that that starts to tense the walls, that's your stressed volume. And this is a very dynamic variable in physiology. And normally in the resting patient, just prior to the OR where this was studied, the stressed volume is about 30% of your blood volume. And you can change that. You can recruit unstressed volume into stressed volume, and that, by an adrenergic response, that's going to increase your mean systemic filling pressure. So this is your pressure head. This is what's pushing flow into the right atrium. So now I want you to imagine a patient that you fluid load. You give this patient 3 liters of crystalloid. You've increased their total volume. You've made them hypervolemic, okay? Buzzword. This is your, quote, volume status, end quote. And you've pushed up their mean systemic filling pressure, so the venous return curve has shifted to the right. So because you've got a higher pressure head, there's going to be more venous return, more volume coming back to the right atrium for every given right atrial pressure. And this is what changes in volume status does to venous return. Similarly, if you bled that patient out, if you shot them in the stomach, and it's kind of violent, I'm sorry, but they bled out a few liters, for whatever reason, you're going to drop your volume. You're going to become hypovolemic, buzzword, right? Volume status. Your body will try and compensate by releasing catechols, which will recruit unstressed volume into stressed volume, but you'll nevertheless still drop your filling pressure, your mean systemic pressure, and your venous return curve will shift to the left, and that's what that situation would look like. So that's inflow, okay? First determinant of the CVP. Well, what about outflow? So what determines how much volume leaves the right atrium over time? Well, that's your Starling curve, okay? This is, I forget when Starling described this, but it's got to be close to 200 years, if not more, I think. And that is, if you stretch myocytes, they contract harder up until a point. If you stretch a myocyte, you get stretch-induced calcium sensitivity in the troponins, and that causes more of a contractile strength within a given myocyte. And within the heart, in vivo, not just a single myocyte, you have an increase up into this plateau portion. And this doesn't have to do with really, the plateau doesn't really have to do with the stretch of individual myocytes. It actually has to do with the pericardium and mediastinal restriction. But the nice thing about the cardiac function curve is that if you put more in, you get more out. And it's this sort of beautiful evolutionary response to protect your lungs. Because if your heart just beat forward more and more and more blood, then you would go into pulmonary edema pretty quickly. So up until a point, what your right ventricle senses, the lungs get up until a safe, or unsafe point, and then you start essentially dumping excess fluid into your extremities rather than delivering it to the lungs. So as we've talked about in previous chapters, you can shift your cardiac function curve. So for this right atrial pressure, you'll have this much cardiac output, and if it gets higher here, but if you were to shift the curve up and to the left, okay, increasing heart rate, increasing contractility, lowering afterload. There's lots of things you can do to shift up the cardiac response curve, as Arthur Guyton called it, not just improving contractility. But in this patient, for the same pressure, they're going to have more of an output. And this is an improvement in the cardiac function curve. And conversely, you can have a worsening cardiac function curve. You could have bad aortic stenosis. You could have a valvulopathy. You could have heart failure with a low contractile state. You could have a heart rate of 15 or a heart rate of 200. All of those things is going to shift your curve down and to the right. And for a given filling pressure, you're going to expel less, okay? And so it's the relative contributions of inflow and outflow that determines your right atrial volume, and therefore your right atrial pressure, and therefore your CVP. So you can see at this point how bloody silly it is to consider volume status as something the CVP can just directly tell you, because there's so many other physiological determinants of the CVP other than volume status. Okay, so your CVP is determined by the intersection of these two curves. So this is your CVP coming together. And I want you to consider a few clinical scenarios to help illustrate this. So check out this arrow here. This is steady state. This is let's call this the euvolemic normal cardiac function patient with a good inflow, a normal inflow, and a normal outflow in this right atrial volume. So I want you to consider a patient with more inflow. Okay, so this patient, let's say this is a 20-something-year-old patient who's just done a medical mission in Africa, and he contracted P. falciparum malaria, and he gets off at the airport at JFK and comes to Bellevue Hospital because he's febrile to 106 and he feels pretty miserable. And you see that, and you begin treating him with lots of fluids before you know he's got malaria. And you shift his venous return curve way over because you give him 10, 11, 12 liters of crystalloid, because you really just can't keep up with his insensible losses, or so you think. So you've shifted his venous return curve way over to the right. But he's a young, healthy guy, and he, in response to this inflammatory state, upregulates his outflow. Okay, so look at the outflow arrow. So it goes from normal to his heart, really revs up. So how's that going to look on the Guyton analysis? Well, his cardiac function curve is going to shift up along this higher venous return curve. And now look at his right atrial pressure compared to the first normal healthy guy who's just sitting around watching this lecture. Okay, think about it. Okay, now another clinical scenario. This third guy or gal, low inflow. Okay, what's going to happen to the venous return curve? Well, the mean systemic filling pressure is going to shift to the left because this patient was on a cruise and picked up some horrible norovirus and has been blasting his guts out for the last 72 hours, and he's very hypovolemic. So you've shifted his return curve to the left. But this guy is also known to have pretty bad aortic stenosis. He's a vasculopath. He smoked for a while. He's got bad flow limiting coronary disease. So as his diastolic blood pressures go down from the hypovolemia, his coronaries perfuse less. He actually starts getting relatively ischemic. His heart really cannot keep up with this physiologic stress. And so his heart actually, despite the low inflow because of the hypovolemia, his heart actually is also impaired. So what does that do to his cardiac? Well, his cardiac function curve shifts down and to the right. And oh boy, these three totally different patients with completely different volume statuses, stati, I don't know what the plural of status is. Look at them. They all have the same right atrial pressure. They all have the same CVP. So what's the moral of the story? Using CVP as a marker or as the clincher for volume status does not make very much sense at all. And the fact that this has been studied, I just find a little bit amusing, because if you understood this, you would never use the CVP as a it's any wonder that when you look at the CVP as a marker of volume status, it's like flipping a coin. So the best analogy I've seen in the literature on this is like equating the CVP to pH. And I think we think about pH frequently in the ICU, and we realize that there's lots of physiological determinants like the CVP of pH. There's primarily respiratory causes, and there's primarily metabolic causes. We have to think of the CVP as the same way, as that there's venous return causes, and then there's cardiac output causes, and each of those broken down in multiple different variables. So giving the CVP and asking the patient's volume status would be like giving the patient's pH and asking the patient's lactate concentration. On the face of that sounds absurd. If I told you the patient's pH was 7.2 and I demanded of you the patient's lactate, you'd look at me like I'd lost my mind, and I really had, because lactate is just one small contributor to pH, just like volume status is to CVP. So now I want to move on from volume status and move on to volume responsiveness. So volume responsiveness is the ability to augment one's cardiac output in response to a fluid bolus or an increase in your distending pressure or transmural pressure. And this is really just testing the Frank-Starling mechanism in a patient. So volume responsiveness would therefore apply to more or less this green portion of the cardiac response curve. That is the ascending portion. If you're increasing pressure along this point, cardiac output goes up and up until you get around here, and then what happens? Well, you hit the plateau. And this is when you just increase pressure and you don't increase cardiac output. And this is some people call wasted filling pressure, and that is just you're just increasing pressure without any increase in cardiac response, and this is going to worsen your risk of peripheral edema as your CVP goes high. But this is still very difficult to predict in any one patient based on any one right atrial pressure, because this curve shifts, and it's different between patients, and it's different within one patient over a given disease state. This cardiac function curve will swap. So if whatever reason the cardiac response curve shifts down and to the right, well, now you've changed their volume responsive window. So they're much more likely to be a volume non-responder rather than a volume responder. And it's difficult to predict where this curve is in any one given patient. So despite that, there is some okay evidence to help guide us here, and this is research that's about 5 or 6 years old now, and in most patients, in most clinical states, I think these patients were I think they were cardiothoracic ICU patients, but a CVP above 10, and especially above 13 to 15 millimeters of mercury, made volume responsiveness very unlikely. So if you were at a CVP that high, you were more likely to be on that plateau portion of your cardiac function curve. But there's caveats, and we're going to talk about those caveats. And the caveats essentially stem from anything that can shift your cardiac function curve rightwards. And we talked a lot about this in chapters 3 and 4 in variables that will shift your cardiac function curve rightwards in relation to the systemic venous return curve. And one of the more common causes of this is the application of PEEP, or the establishment of auto PEEP or intrinsic PEEP. Mediastinal edema may do it, but all these things will shift your cardiac function curve rightwards, and you can still therefore have a high CVP and still be on the ascending portion of your cardiac function curve. But as I mentioned, the plateau portion can be as low as 2, and so a low CVP cannot rule in volume responsiveness. And in that study that looked at a CVP of 10, I think that even if you had a CVP less than 5, there was still 25% of patients who did not respond to volume. So despite a very low CVP, or a very low CVP, at least for ICU patients, a good portion of them did not respond to fluids. So this is going to be an example of one of the caveats of why you can have a high CVP and still be volume responsive. This is an illustration of something that can shift your cardiac function curve rightwards relative to the systemic venous return curve, and therefore potentially place venous return on the ascending portion of the cardiac function curve, despite there still being a high central venous pressure. So this diagram may look a little bit scary, but you can go back and review either the introduction and overview, which goes through the highlights of chapter 1 and explains what this means, or you can go back and review chapters 1 through 4. But this is basically the Campbell diagram here, with lung volume on the z-axis. This plane is going into the screen. On the x-axis here, this is pleural pressure or intrathoracic pressure. I've left out the pulmonary elastance curve, which would normally curve along here, or the pulmonary compliance curve. This dotted line here is the chest wall compliance curve, okay? And then this curve here, this dotted line, is the compliance curve of the respiratory system, that is the lungs and the chest wall together. And then this curve on top of that represents the airway resistance seen by the ventilator. And again, this is extrapulmonary ARDS, which is typified by a very low chest wall compliance as opposed to a low pulmonary compliance. And so this shift downwards, normally the chest wall compliance curve would run up here, but the shift downwards and to the right of the chest wall compliance curve means that there will also be a downshift in the respiratory system compliance curve, because the chest wall partially makes up the respiratory system, but also because pleural pressure tracks the changes on the Campbell diagram of the chest wall compliance curve. The shift down and to the right of the chest wall compliance curve will mean that pleural pressures will raise compared to a patient with normal chest wall compliance, say with the application of PEEP. So we're going to now superimpose the Guyton analysis on top of this. Okay, so now we have blood flow on the y-axis, right atrial pressure, so pressure is still on the x-axis, and the reason that you can superimpose the right atrial pressure with the pleural pressure on the Campbell diagram is because at a cardiac output of 0 here, your right atrial pressure assumes intrathoracic or pleural pressure. So that's why this curve shifts with changes in pleural pressure. So this point here is FRC, this dot that's faded out because this is where the pulmonary elastance curve would intersect with the chest wall elastance curve. So FRC, the intrathoracic pressure, correlates with this portion of the cardiac response curve. That is, your right atrial pressure would assume intrathoracic, baseline intrathoracic pressure with a cardiac output of 0. And now we're going to apply PEEP to this patient. So you're going to start at FRC, we're going to intubate the patient and give some PEEP. So what's that going to do? Okay, so that's going to shift pleural pressure upwards along the elastance curve, and therefore this point here will shift along in parallel with intrathoracic pressure. So the cardiac function curve shifts rightwards with the systemic venous return curve. So at this point here, you're kind of approaching the plateau portion of your cardiac response curve, so you may not be terribly volume responsive here. But with the application of PEEP, you've now shifted the cardiac function curve rightwards, so you may be more volume responsive here. Now the venous return curve also changes in response to PEEP, which I'll talk a little bit more at the end of this lecture, and which is discussed much more in chapters 3 and 4. But you can see that this is just an example of how you can have a clinical state where CVP is higher or high, but you can still be on the ascending portion of your cardiac function curve. And this is just the application of a breath on top of the PEEP. Okay, so a little bit more about volume responsiveness. If there's any doubt about a patient's CVP and ability to tolerate volume loading, some authors suggest the fluid challenge. Really, I guess this kind of is the gold standard of determining whether or not somebody's volume responsive. That is, give them fluid and see if they respond. So you bolus the patient quickly, usually less than over half an hour, and you do this in a way to increase their CVP by about 2. And the reason 2 is chosen is because this is usually the amount of difference that can be reliably detected by an observer. And again, this is a CVP increase by 2 at end expiration, at the end of the A wave, okay, not that average number that you see on the screen. And then if you do that and cardiac output goes up, preferably direct measurement, then you've got a fluid responder. And you have to bear in mind that surrogates for cardiac output, like blood pressure, remember blood pressure is a surrogate for cardiac output because blood pressure is determined by cardiac output and systemic vascular resistance, so there can be changes in that variable, which may or may not cause there to be changes in blood pressure. And similarly, urine output may miss true responders. So where does this fluid challenge physiology come from? Well, again, this is a big assumption, but we talked about a few slides ago that in most people the plateau probably occurs somewhere around 10. Again, it's not a hard and fast rule, or it's not really written in stone. It's not true for all patients, but if we assume that the plateau occurs here on the x-axis at 10, right? And then we assume that a normal cardiac output is about 5 liters per minute. So that's here, right? So we've sort of created a bit of a triangle. And so you can then calculate the slope of that triangle. And that slope is 0.5 liters per minute per millimeter of mercury. So that means for every 1 increase in millimeter of mercury, you should have roughly 500 cc's per minute increase in cardiac output in the quote-unquote normal perfect patient. Okay, and so in Sheldon Magder's studies, he uses an increase in cardiac output of 300 cc's per minute per meter squared per 2 millimeter of mercury increase in CVP, and 300 in this is chosen because that's basically how reliable a PA catheter can be in terms of making repeated accurate measurements. So that's it for the determinants of the central venous pressure, and the CVP is a static measure of volume status, which you now know is silly, and is a static measure of volume responsiveness, which is not great, but if it's greater than 10 or certainly greater than 15, the patient is unlikely to be a volume responder, except in certain clinical situations, one of which being extrapulmonary ARDS. So now we're going to move on to dynamic assessments of the central venous pressure.